The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.
Hello and welcome to the ASCO Guidelines podcast series brought to you by the ASCO Podcast Network, a collection of 9 programs covering a range of educational and scientific content and offering enriching insight into the world of cancer care. You can find all the shows, including this one, at asco.org/podcasts. My name is Brittany Harvey, and today we're continuing our series on the management of immune-related adverse events. I am joined by Dr. Milan Anadkat from Washington University in St. Louis, Missouri, and Dr. Aung Naing from the University of Texas M.D. Anderson Cancer Center in Houston, Texas, authors on management of immune-related adverse events in patients treated with immune checkpoint inhibitor therapy, ASCO Guideline update, and management of immune-related adverse events in patients treated with Chimeric Antigen Receptor T-cell therapy, ASCO Guideline. And today we're focusing on cutaneous toxicities in patients treated with immune checkpoint inhibitor therapy. Thank you for being here, Dr. Anadkat and Dr. Naing.
Thank you for having us.
Thank you.
I'd like to note that ASCO takes great care in the development of its guidelines and ensuring that the ASCO conflict of interest policy is followed for each guideline. The full conflict of interest information for this guideline panel is available online with the publication of the guidelines in the Journal of Clinical Oncology. Dr. Anadkat, do you have any relevant disclosures that are directly related to these guidelines?
As listed in the document, I don't have any direct disclosures. I do have a number of indirect disclosures as I've consulted on similar topics in the past.
Thank you. Then Dr. Naing, do you have any relevant disclosures that are related to these guidelines?
I do not have.
Great, then let's get into the content of this guideline and the cutaneous toxicities that we're here today to talk about. So Dr. Naing, what are the immune-related cutaneous toxicities addressed in this guideline?
Well, with the advancement of immunotherapy, we've seen better response in our cancer patients. However, together with such positive outcomes, we are also seeing side effects caused by the immunotherapy. Disruption of the homeostatic mechanisms include a unique spectrum of side effects called immune-related adverse events, commonly called irAEs. The most common immune-related adverse events in patients receiving checkpoint inhibitors are dermatitis, enterocolitis, transaminitis, and endocrinopathies. However, if you look at the most commonly reported irAE of any grade, it is dermatologic toxicity. So here in this guideline, we address how to take care of the patients when they are having the side effects, particularly with the cutaneous toxicities. So when you look at the time to median onset of skin toxicities, it ranges from 2 to 5 weeks. Using CTCAE criteria for grading is a challenge for skin toxicity, as it may not reflect the true picture. So therefore, severity may be graded based on body surface area, tolerability, morbidity, and durations. Those are the points also we discuss in this guideline. Broadly speaking, there are 3 groups of cutaneous irAEs. They are rash inflammatory dermatitis, bullous dermatosis, and finally severe cutaneous adverse reactions, scar. It is important to have thorough physical exam and rule out any other etiology of skin problems. In general, it's also important to work closely with our colleagues from dermatology. While some of those low-grade skin toxicities could be treated in outpatient setting, consulting the cases with dermatologists is important for higher grades of skin toxicities such as bullous dermatosis and scar. My colleague Dr. Milan Anadkat will follow with a discussion on the role of dermatologists in taking care of patients with cutaneous toxicities caused by immunotherapy.
Thank you, Dr. Naing, for reviewing those. So then you just mentioned 3 categories of toxicity, and I'd like to review the key recommendations for each. So Dr. Anadkat, starting with what is recommended for the identification, evaluation, and management of rash or inflammatory dermatitis?
Thank you, Brittany, and thank you, Dr. Naing, for teeing up this discussion. I think as was mentioned, there are three major categories of cutaneous toxicity that are seen from immunotherapy. By and large, the most common is rash or inflammatory dermatitis, from which there are multiple different phenotypes or looks by which physicians may be seeing. The most common phenotypes within rash or inflammatory dermatitis, which account for over 90% of the cutaneous toxicity seen from immunotherapy, include lichenoid, which is a purple, flat-topped, bumpy rash that can involve the skin or the mucosal membranes, a psoriasiform, which resembles psoriasis, morbilliform, or often termed maculopapular, which resembles a measles-like pink exanthem over the trunk, or generalized eczema and itching. So what's important is identifying the particular phenotype and categorizing it as an inflammatory dermatosis and excluding the other two phenotypes of cutaneous toxicity, such as bullous dermatoses or severe cutaneous adverse reactions.
Great. And then moving into that second category that you both mentioned, what are the key recommendations for bullous dermatoses?
And so the key phenotypes for bullous dermatoses, by and large, is bullous pemphigoid, which is the most common phenotype seen in this category, although other phenotypes resembling autoimmune bullous diseases, such as pemphigus or bullous drug reactions, may also be seen. With bullous pemphigoid, we see tense blisters or tense bullae, frequently overlying a bed of erythema on the skin. Patients typically complain of considerable itching, far more than pain, with this category of eruption.
Got it. Thank you for reviewing that for bullous dermatoses. So then the third group is severe cutaneous adverse reactions. So what are the key recommendations there?
And so the third group, being severe cutaneous adverse reactions, is a term used worldwide to encompass conditions such as Stevens-Johnson syndrome, toxic epidermal necrolysis, acute generalized exanthematous pustulosis, and DRESS or drug reaction with eosinophilia and systemic symptoms. These are fortunately rare, but can be life-threatening skin eruptions. They account for less than 1% of all skin reactions seen from immunotherapy. When practitioners are approaching a patient who may potentially have one of these conditions, patients typically will exhibit symptoms of malaise, fatigue, fever, and a dramatic cutaneous eruption, which will either present with peeling or sloughing of the top layers of the skin, or a generalized erythema covered with multiple sterile pinpoint pustules. Oftentimes, there are associated symptoms of lymphadenopathy and end organ toxicity that is noticed simultaneously, such as hepatotoxicity or eosinophilia or acute renal failure.
Great. I appreciate you reviewing the identification of all three of those groups. So then I'd like to hear from you both on this last question, but in your view, how will these recommendations for the management of cutaneous toxicities impact both clinicians and patients?
I would say that, recognition of the toxicity is really important, particularly if you can actually catch the toxicity when it is in the mild grade, if you take care of them. Then you can actually stop them from being mild to severe toxicity. That's number one. Number two is, in that way, we may not have to hold or stop the immunotherapy treatment that could be beneficial to the patients. And also, working together with the dermatologist is very important because, as I discussed earlier, some of them we could take care of as an outpatient, but there will be certain dermatologic toxicity, so where we need to work closely with our dermatologists. And please also remember that these are the guidelines. You will be seeing the patients, in the setting. So I think using the guideline and clinical judgment, that would actually help our patients at large.
Yeah, I think that's excellent. One I think important aspect of these guidelines is not only to correctly identify the phenotypes of cutaneous toxicity, but as Dr. Naing mentioned, It assists in management of these toxicities. The goal of these guidelines, especially as it pertains to the skin toxicity, is to accurately identify what toxicity is occurring for the patient, but then more importantly, to guide on appropriate management strategies to allow the patient to continue on immunotherapy and minimize or avoid unnecessary treatment interruption or treatment discontinuation. The guidelines assist in management strategies according to the severity by which patients present. And as mentioned, I think ultimate priority will be given to the practitioner directly treating the patient, but consideration towards not only extent of body surface area involved, but severity of cutaneous eruption is thoroughly reviewed. And in addition to phenotype, including such patient-reported outcomes such as degree of pain, itch, or interruption on activities of daily living, help guide the degree of management that can be provided.
Those are excellent points. I want to thank you so much for your work on these guidelines and for taking the time to speak with me today, Dr. Naing and Dr. Anadkat.
Thank you.
Thank you.
And thank you to all of our listeners for tuning in to the ASCO Guidelines podcast series. Stay tuned for additional episodes on the management of immune-related adverse events. To read the full guideline, go to www.asco.org/supportive-care-guidelines. You can also find many of our guidelines and interactive resources in the free ASCO Guidelines app, available in iTunes or the Google Play Store. If you have enjoyed what you've heard today, please rate and review the podcast and be sure to subscribe so you never miss an episode.